So, as Sir has mentioned, for any robotic or computer-assisted surgical system, it's imperative to feed the computer the anatomical data of the patient to orient itself in real time. So this is called mapping of the landmarks, which is done intraoperatively. It can either be corroborated with the pre-op imaging, or it can be independent depending on the system. So on the basis of that, the classification of robotic systems is either image-based or imageless, which is what we've been talking about all morning. So if you just look at a brief overview of all the 5 major robots right now, I'm speaking about the Striker Mako right now, which is a CT based. The Rosa, you can either use an MRI or X-ray, or it can also be used imageless. The Nevio is imageless, Merrill is CT, the Cubis, and the Velis is imageless as well. So if you see, I'm going to be speaking basically about the pre-op planning. This is where the maximum benefit in terms of planning of different deformities comes into play in a CT-based robot. So the first thing is, once the 3D CT scan is done, either it's a TKR, partial knee, or total hip, all these films are taken together. They're combined to form a 3D model. And this is called a segmentation, which is done by the product specialist before the surgery even starts. So this is not something we have to worry about. It's done by the technical team, and they bring it to us the day of the surgery or the day before, depending on when you want to plan it out. So in the TKR, you can do this planning, partial knee, this kind of planning, and the total hip, this kind of planning can be done. So as I mentioned earlier, the registration is a process with the CT-based model is mapped onto the patient's bones. Won't go into too much detail, it's already covered. And the advantages in the 3D CT image-based is the accuracy of the bone registration and the landmarks. You understand the pathology better, location of osteophytes is you can find, bone defects, metaphyseal cysts, quality of the bone, and presence of any occult fractures, etc. So if you can see here, I know before I go into the surgery where my osteophytes are going to be, if there's a big defect or not. Just by seeing the X-ray, you may not be able to, of course, you can see it, appreciate it, but you can see for sure exactly where all these things are. You can also plan for the need, if there's any need of stem extension, augments, or bone grafts, depending on the defects. And very importantly, you can do your implant sizing beforehand, and also your posterior corner offset can also be determined beforehand. You can shape match your femur to the trochlear groove. You can check the medial lateral fit. You can find out the rotation axis and the osteophytes. And sagittal plane, you can see the slope of the tibia, and as well as the as I mentioned earlier, the PCO. And as mentioned earlier, it can be moved in 6 degrees of freedom. So you take the femur and the tibia in all the different planes, it can be moved around just to make sure that you get a better balancing. So can we do severe varus cases with the robot? A lot of people said, yeah, we can do the same thing with a regular knees, but what about severe varus, severe deformities? Can they be helped with this or not? So first you have to understand the concept of pre-balancing. It's the ability to move the implant position to achieve balance, just like Dr. Nilen Patel sir has mentioned, before the bone cuts. So before cutting itself, you're able to balance just by adjusting the implant. So if you see in pre-balance, in robotic TKR, you plan, assess, balance, and then cut. Unlike in manual where you plan, cut, then you assess, and then you balance it out. So this is called as pre-balance. So pre-balance can be achieved by pre-resection or mid-resection. What that means is, if pre-resection, all the gaps are balanced by moving the implants, and then you make all the cuts simultaneously. And in mid-resection, if the gaps are not getting balanced by pre-resection, you take 2 cuts, that is the distal femur and the proximal tibia. Then you do your little bit of balancing, and then you get your balancing of the joint. So pre-resection, if you can just see this video over here, initially we start off with 23, 20, 23, 20 gaps. And just by giving 2 degrees varus on the tibia, 2 degrees varus on the femur, then external rotating the femur by 2 degrees, and then raising the tibia by 2 millimeters, we got equally balanced gaps. And then you take the cuts. So this is called a pre-resection. So mid-resection, you'd cut the distal femur first, and then the proximal tibia, and then you do your medial releases, and then you'll finally get your cuts, and you'll be able to do it. But what if you're not able to get your pre-balance even after mid-resection? That is when we devise something known as the enhanced mid-resection. You take a provisional cut of the posterior femur, then you take out the osteophytes at the back, get a bit of opening up over there, and then you get your pre-balancing. So this is, for example, this is a case which is severe varus. So you see it's 28 degrees of varus preoperatively. By removing the initial osteophytes, you brought that down to 19 degrees of varus, but your gaps are still different. The medial is only 14 and lateral is 23. So then what we do your functional positioning of the implants. So we have given 3 degrees varus, 1 degree varus on the femur, and 3 mm raise the tibia. So now you've got the deformity down to 11 degrees, and the gaps have come a little closer. From 1823, they've come to 1419, but they're still not balanced. So then you do your provisional cut, you bring your femur down, just take a 4 mm cut, remove your osteophytes in the back, and then your deformity is coming down to 4 degrees and almost equal to 17, 18 gaps. And of course, finally, you check your extension gap is balanced. And then you can do a provisional cut. It also allows you to put your knee tensioner and balance your femur in flexion. And the rest of the cuts are completed. And finally, you get a nicely balanced 20-20-20 with an 11 poly. So this is how we've managed with the enhanced mid-dissection workflow. So then you go about valgus knees. The most important word is here, the trochlear matching. So what we can do is, now you see this case, it's 28 and 23 mm gaps with a valgus deformity of 24 degrees. So first we proximize the tibia, right, and we distalize the femur. So you bring down the gaps, you put valgus on the femur by 2 degrees, and we're almost there, 1915, 1915. Then, of course, you do your regular steps like doing posterolateral corner release, and then ITB pie crusting, etc. And you manage to balance out your extension gaps, 1919, but your flexion gap on the lateral side is still tight. So then we do something which you would never think of doing in a conventional case. We actually internally rotate the femur by 2 degrees, and then we've actually balanced out your gaps. But we would never think to do that because you'll get patellar maltracking, right? But if you see here, we can actually match the trochlear groove, and we can see whether we are maltracking or not. So even without, if you're not maltracking, we can actually put that 1-2 degrees of internal rotation without any issue at all. You see, it's nicely matching the trochlear groove. Okay, and finally, you get 1919 gaps. You've nicely balanced out your valgus knee. So what about cases with big bone defects? We have this gentleman who has a huge cliff over here in the middle of the tibia. And I'm not going to go too much detail, but just see how he's walking with a lot of varus thrust. And if you can see the planning itself, we have a huge, like a fall off like a cliff over here. And initially, if you can see, the gaps are -14 because they're overlap and 14. And after doing a bit of stressing, we got 13-19 gaps. After downsizing the femur, the tibia, and doing all your changes, we managed to get a nice, very balanced joint. And what about bone defects in hip as well? So normally we would be contemplating whether we have to do something more in this particular joint. But here, first of all, we get a nice pre-op visualization, a 3D visualization of this joint. And we can find that there's a very good fit with a regular primary cup. We don't even have to go for highly porous coated anything here. And we can see in the transverse view, the sagittal view, and the coronal view that we have a good hold over there. And this is a pre-op visualization of the post-op X-ray. And we can always get that in the final post-op X-ray. It's almost always accurate. What about occult fractures? In this patient, 8 months old lateral tibial condyle fracture. And if you see this video over here, you can see that it tells us where that fracture is and whether it's there is any discontinuity at all. You can see over here. So all this planning can be done. And just go through the CT as well. You can see there, and you can just plan it according to this, and you can get a nice X-ray without any issues at all. What about malunions and extra-articular deformities? This X-ray, if you have an extra-articular deformity like this with malunion, of course, it's going to give you a pre-op visualization, and you do your planning itself. But best thing is, because it's a CT-based, it has a whole alignment axis and everything. So you know that you're at 12 degrees of varus, and then you do your balancing out. And after putting in 3 degrees of varus and 1 degree varus here and external rotation on the femur, you got nicely balanced gaps and you get a nice post-op X-ray. What about if you have implants in situ? This gentleman had an old ACL reconstruction, and after doing a bit of planning, making sure that this screw doesn't have to be removed, we have taken the saw cuts in the haptic boundaries, and we managed to go ahead without having to remove that screw, just by doing a little bit of playing around. And of course, same in the hip as well. You can manage to avoid the removing any plates. This case, we would have thought of maybe you have to remove the plate or some screws, but just by looking at the planning, we see where the screws are exiting, and we managed to do without taking out anything. And we also got in a screw for the cup as well. Post H2 also can be done. We just have to remove one screw anteriorly because it was going to hit the keel. We have all that planning beforehand now because of the CT scan. Dysplastic hips also, we have the visualization of where the best bone stock is going to be, and then we can just put the cup in without any issues at all. This is the latest thing that Dr. Mahesh Kulkarni sir was mentioning as well about the spinopelvic relation and the virtual range of motion. You know, the planning, and it just tells us how much the femoral version is going to be and the stem version. So in this particular case, at 40-20 degrees, which we normally put, okay, aluminic safe zones, you say, this is showing that there is impingement in this virtual range of motion. So what we have done, we've actually reduced that version of the cup to 12 degrees, and combined antiversion came up 32. and we manage, and this is the post reduction view, and the X-ray is good and very stable. We don't normally go down to that much of reduced anteversion, but with this VROM, we know that we can safely do that. So this is the different type of cases that we can do with CT scan. Thank you.